Dopo una prima terapia con un farmaco anti-CD38, considerati farmaci molto importanti per la cura del mieloma multiplo, ha senso utilizzarne un secondo a fronte di una risposta parziale o mancata? Lo abbiamo chiesto a un vero esperto, il professor Lee, che abbiamo incontrato qui a Bergamo nell'ambito di un meeting incentrato proprio sul CD38 che è stato organizzato da SOHO Italy. Professor Lee, is there a role to retreat with an anti-CD38 drug a patient who relapsed after a CD38 drug?
Yeah, so this is going to become a much more relevant question moving forward in multiple myeloma since we're using CD38 monoclonal antibodies in earlier lines of therapy, particularly now in newly diagnosed patients. So nearly all patients will be exposed to CD38 monoclonal antibodies at the time of relapse at some point earlier on in their treatment course. And so I think the first question to ask is if the patient is exposed but still sensitive to the anti-CD38 monoclonal antibody, or are they truly exposed and refractory? And so I think of a patient that received a fixed duration of a CD38 monoclonal antibody combination early on and then had a long treatment-free interval between their last exposure to either daratumumab or isatuximab could certainly then be retreated with an anti-CD38 monoclonal antibody combination. And I think this is something that I do in my routine clinical practice with good results. On the other hand, if the patient is not only exposed but refractory to their anti-CD38 monoclonal antibody, then we know the outcomes are going to be less optimal in those situations, and that the responses, and not only the responses, but also the duration of response and progression-free survival will be less than what we had seen in larger clinical trials that didn't include such patients. So if one were to employ that strategy, then certainly doing a different combination of a CD38 monoclonal antibody that was different than what the patient previously received would be the best option, but also having the longer duration between the last CD38 exposure to the next CD38 exposure, at least 6 months, would be ideal to maximize the chances of success. But certainly, in summary, in CD38 exposed patients, I think certainly there's a role for retreatment. For CD38 refractory patients, probably less of a role unless used in a novel combination.
And is the same if the patient has received Dara first or isatuximab first?
Yeah, so currently we don't have a whole lot of data on sequencing of Dara, then Isa, or Isa, then Dara. There's several small studies, but practically speaking, the same would be the case. And so we would expect the same sort of approach, whether you use Isa or Dara up front, that again, retreating with someone who's exposed but not refractory may be reasonable. Someone who's actually refractory would have a less promising outcome that would be anticipated.
Professor Lee, there are other ways, in addition to these two drugs, to target CD38.
So beyond naked monoclonal antibodies like daratumumab and isatuximab, there are other strategies looking at targeting CD38 in multiple myeloma. And this can be in the form of other novel immunotherapy constructs, such as immunocytokines, such as bispecific antibodies, and such as CAR T therapies. And probably one of the drugs that has more mature data to date would be a drug called modakafusp alfa, which is being developed by Takeda. And this is a CD38 antibody that has binds to a different epitope on CD38 than isatuximab and daratumumab. And it's fused to an immunocytokine, actually, an attenuated interferon alpha 2b. And so not only is it targeting CD38, but it's CD38 plus something else, an interferon alpha 2b. And so it can selectively deliver the interferon signal to plasma cells and other CD38 expressing immune cells. And so data has been presented in a phase 1 study with this particular drug with encouraging results so far, but particularly in anti-CD38 refractory patients with responses of 35 to 40% in such patient population. So this is proof of concept that targeting CD38 in truly patients who are refractory to CD38 monoclonal antibodies is possible if perhaps using a different mechanism of action targeting CD38.